So, Dr. Scholz, we've been going through the 101s of prostate cancer and kind of the basics, and I think that this is a question we often get, and I want to kind of expand a lot on it. We see urologists, we see primary care physicians when it comes to PSA, we see medical oncologists, radiologists. Can we just break down the medical team for the patient? So, when a patient's, getting a PSA in a medical office with a primary care physician, they're first sent to a urologist. So, I guess my first question is, what is the difference between a urologist and a medical oncologist?
It's a big difference because the training after medical school is 4 years or 5 years of urology, and for a medical oncologist after medical school, 4 years or 5 years of hematology oncology. So it's a totally different training program. The thing that's really unusual about prostate cancer, the most common cancer in men, is that medical oncologists typically are not involved in the early management of prostate cancer, as is the case for, say, breast cancer, colon cancer, lung cancers, and all the other common cancers, where medical oncologists act like the hub of the wheel, the primary care organizer for complex multimodality therapy. So if someone was diagnosed with breast cancer, they're going to need chemotherapy and radiation, maybe surgery. Someone has to take control and be the captain of the ship, and that's always the role of the medical oncologist. The medical oncologist is an internist who has to be board certified in internal medicine and then subsequently does postgraduate training. So the training after medical school consists of 3 years of internal medicine, then maybe another 2 to 3 years of oncology and hematology. The medical oncologist is not a surgeon, and he or she is not a radiation therapist. These are other specialty trained physicians that are very good at what they do, surgery and radiation. But when do you need the surgery? When do you need the radiation? Someone has to have an overview of optimal management. Do you need both surgery and radiation? Do you, in some cases, need neither? This role of medical oncologists in all the other common cancers is not implemented in the field of prostate cancer, the most common cancer in men, as I mentioned before. This is just historical. Urologists as a specialty were created in the early 1900s. Medical oncology as a specialty didn't start until the 1960s and 70s. And historically, since prostate cancer was thought to be a rather low-grade process, medical oncologists have deferred to the surgeons, where in breast, colon, and lung cancers, which were much faster-growing cancers, the medical oncologists basically moved in and took over the field and relegated the surgeons and the radiation therapists to a consulting role. So I know it's kind of a long answer, but the landscape is such that it's very unusual to run across medical oncologists who see early stage prostate cancer. Medical oncologists may get involved after the cancer metastasizes, when chemotherapy might be needed, but typically they are not involved in the early stages. And when you consult a medical oncologist for advice about newly diagnosed localized prostate cancer, it's quite possible that they will not be very knowledgeable about it, and often will just refer you to a urologist, refer you to a surgeon, because historically that's the way we've managed early stage prostate cancer.
Basically, urologists are not trained in internal medicine at all?
Correct. Urologists are primarily trained as surgeons, and there was an era 30, 25 years ago where medicine was simple enough that someone could treat urinary tract infections with antibiotics and learn how to do surgery to, reduce the size of the prostate. And it could all be handled under one roof. The reality with the modern world, where technology is exploding and we know so much more now about all different diseases, including prostate cancer, that you do need a multidisciplinary approach, but it hasn't been adopted yet for prostate cancer, sadly. Prostate cancer has been left behind in this modern world where you don't have cancer specialists helping out with early stage prostate cancer.
Yeah, and I think that's very frustrating, especially from the PCRI perspective, because we're seeing so many men get surgery when there's so many other options that they can get, and they can get customized treatment according to their particular type of prostate cancer. I think that sending everybody to urologist, that's like the first step that we hear from every patient we talk to. And so often it's hard to explain that all prostate cancers are different and that there are so many unique treatments. And especially in the last 10 years, there's been such a boom in seeing the industries come to play where there's so many treatments left and right. And it really does need that oversight. Well, let me ask you this. So how many times are urologists prescribing other treatments outside of surgery?
They do. I think an interesting statistic is that around 2007, the idea came up that Gleason 6 prostate cancers don't need surgery or radiation. At that time, about 100,000 men a year were getting surgery or radiation who didn't need it. We have 200,000 diagnosed every year, and about 100,000 are Gleason 6. And as of 2022, about more than half of those men are now being put on active surveillance. Sadly, it should be all of them all 100,000 should be going on active surveillance, and that is not the case. So the old saying is, if you're a hammer, everything looks like a nail, and if you're a surgeon, the default thinking is, well, we'll cut it out. There is a lot of unnecessary surgery going on to this day, though it's nowhere near as serious as it was 10 years ago.
So ideally, when is the right time for a patient to bring on a medical oncologist into their medical team?
Well, first you have to find a medical oncologist that has spent some time working with early stage prostate cancer. They're not common. There aren't very many medical oncologists that specialize in early stage prostate cancer, but the best chance would probably be at some of the academic centers. You still have to be careful at the academic centers because there's a lot of politics, and the urologists have always brought home the bacon. They're the ones that do the surgery and make the money, and medicine is a business. Even the academic centers have an eye on the bottom line, and so sometimes the medical oncologists sort of defer and they just sort of send people to surgery. But they do see early stage prostate cancer and therefore are conversant in some of the options. So I would probably be thinking of a large academic training center and consulting the medical oncology department at that center for finding a medical oncologist who does see early stage prostate cancer.
When you're looking to find the right doctor, there are different things that you can do to find out, how many patients they've treated. Well, in your surgery, in urology, we talk about how many procedures have been done. So you can't really do that with a medical oncologist, so to speak. So do you look at the research papers they've done, patient reviews? What are your suggestions on finding that?
Well, those things are useful. One of the problems is not only that medical oncologists aren't involved in early stage prostate cancer. One of the problems is that the whole field of medicine is exploding with new knowledge. And if you don't have a medical oncologist that has some subspecialization, say genitourinary oncologists, you'll find these at academic centers where they do prostate, bladder, testicular, and kidney cancers. And so that instead of treating 100 different cancers, they're only really trying to be up to date on 4. And that gives you a much better chance of finding an oncologist who has spent enough time in the prostate cancer field that they can give you useful information. A general oncologist these days is just, as is the case for urologists, people are just bombed by all the new information, and they're unable to keep up with all this new information. And this is an important, obviously, cancer where people want to get state-of-the-art care. They're going to have better cure rates, and they're going to have fewer side effects from the treatment.
So when a patient is deciding upon treatment, we've mentioned the primary care physician that gets them typically to the urologist, and then now we've talked about medical oncology. Is there any other physicians that they should interview in regards to choosing a treatment?
So the main specialties that we see in the field of prostate cancer are medical oncologists for more advanced stage, less commonly for early stage unless you go to academia, surgeons, and radiation therapists. There's also sometimes a role for getting feedback from what are called interventional radiologists. Some of them are on the cutting edge of doing focal therapies. And then, of course, pathologists who evaluate the grade of the cancer by looking at it under the microscope. And regular old radiologists, these are the doctors that read the PSMA PET scans, read the CAT scans and bone scans and tell you, is it cancer? Where is it located? Patients often will not interface directly with pathologists and radiologists, but they may interface directly with radiation therapists and with interventional radiologists while they're hopefully shopping around and looking at options. I think that it's a worrisome tendency that people will see one physician, adopt that physician's point of view without getting second opinions and maybe visiting a support group and learning a little bit more about the big picture. This is one of the luxuries that prostate cancer patients have because it's a much, much slower growing disease than the typical lung cancers and colon cancers where you want to move quickly before the cancer spreads. Prostate cancer spreads very slowly.
So with medical oncologists seeing so many different types of cancer and also the fact that there's so many updates happening, is it worth seeing a general medical oncologist versus a urologist? Or is the urologist really the one to see because they specialize in prostate so much?
Excellent question. I think that people often will be disappointed seeing a general medical oncologist for early stage prostate cancer. This is why I mentioned going into academia, finding some of these oncologists that specialize in genitourinary cancers who will be more conversant possibly in early stage prostate cancer. The other thing to consider is that there are some urologists that specialize more just in prostate cancer. As we mentioned before, these doctors are so busy with so many different aspects of healthcare, like urologists who work with benign prostatic hypertrophy, that's enlarged prostates, urologists who work with overactive or leaking bladders, urologists who focus more on kidney stones. There are urologists, oftentimes in the large urology groups, who focus just on prostate cancer. And I've run into some of these urologists, and I've been very impressed that once they specialize just in prostate cancer, they have a much deeper understanding of all the different options that are available.
So I think one thing that we talk about often in Helpline, but I think it's good to mention in this video, is making sure that patients feel comfortable with their doctors. I think sometimes they think, oh, I got my medical oncologist, I'm good, I'm done, let's move on. And the bottom line is if you don't have somebody who's bringing up your quality of life, talking to you transparently about side effects, and helping you where you feel like you can ask questions, and it's not making you feel like an idiot. It's a partnership, it's your health. I think it's important to keep interviewing until you find the right fit in the right person. So many times I've talked to support group leaders or patients, and sometimes I say it took 2 or 3 doctors to really get to the person that would really fight for them, advocate for them, and explain things the way that they needed to. So I think that, we have such incredible patients that are viewing this channel, that are doing their research, and so I would really encourage them to do so. And I'm sure you see that often in your practice, that there are multiple interviews that have been done with some of your patients.
Right, and it's not the way you might approach it if it was a lung cancer or a pancreas cancer, where the clock is ticking and we're concerned about the possibility of spread, and you want to get to the right doctor and get started on treatment and then have discussions. But thankfully, prostate cancer does give you that luxury of time. There's always a sense of urgency when that first heavy blow of the word cancer comes in, and it's hard for people to slow down and realize that this subtype, this exception to the rule, this thing we call prostate cancer, is a much, much lower grade process, that we're making strategic plans for the next 5 to 20 years. Where are we going to be in 5, 10, 15 years? Where with the other solid tumors, pancreas cancers, lung cancers, what we're trying to do is make sure that you don't die within the next 2 years. It's a different priority.
I think that oftentimes we see patients come in and they say, well, Dr. Scholz, you say it's slow growing, it's prostate cancer, it's not as bad as the others, but I have Gleason 9 and I'm very concerned. So can you explain what the time frame looks like to make that decision, even for Gleason 9 patients?
We put prostate cancer on a continuum of these harmless Gleason 6 up to 7s, 8s, 9s, and 10s. Compared to a harmless cancer that never spread, Gleason 9 is something to consider that over the next 5, 10 years, the chance of spread may be 40, 50%. Not all Gleason 9s spread, but some can. They don't spread quickly, and there is enough time. Let's say you allocate 3 to 4 months to learn about prostate cancer and withhold making any final decisions until you've talked to a few doctors. The chances that that would translate into a cancer that hadn't spread into one that did spread is less than 1%.
Today we talked about building your medical team, and as I talk to patients, a lot of times I hear that patients are intimidated in those doctors' offices. They think, I'm new to prostate cancer, I don't know all the terms, and this doctor is a specialist, they know way more than me. So sometimes we don't advocate for ourselves, but the truth is, your research is important, your questions are valid, and I think that those are important things to remember when you're going into those doctors' offices. So if you don't feel the power to advocate for yourself or ask questions, or you're intimidated, please find another physician, or maybe bring somebody who is willing to ask those questions for you. It's important that your health is the top priority, even to yourself. I think oftentimes we honor relationships before we honor what our needs are, and I think that that's an important thing to think about in those medical offices. If you would like help with your individual case, you can visit our website, pcri.org. We have helpline facilitators who are willing to help. These people are patients, and they have been trained by our medical oncology team, and they can answer questions specific to your case. Also, please remember, PCRI is a 501c3 nonprofit organization, so if you would like to partner with us and donate, you can visit pcri.org as well. But most of all, please remember, you're not alone. We are here for you. Much love to you, and I hope you have a great week.